Good morning, and thank you for joining us today for this important dialogue about cancer and health disparities. I am Rodney Wright, Interim Provost and Vice President for Academic Affairs, and it's a pleasure to be here. You know, there are two important conditions impacting people around the world which can only be combated by all of us working together. Florida A&M is proud to partner with and welcome the Honorable Professor Peter and Mrs. Dorothy Nyong'o, all representatives of the African Cancer Foundation. We're also proud to share in the Foundation's mission to promote the prevention of cancer and provide holistic solutions to people affected by cancer. We have a common desire to use our efforts and resources to strive to not only achieve a cancer-free Africa and a cancer-free America, but most of all, a cancer-free world. A key component of the Foundation's success is its focus on using partnerships to affect change. And here at FAMU, through our College of Pharmacy and the Institute of Public Health, we have witnessed firsthand the power of partnering to finding solutions to the world's most pressing health problems. In fact, right here in our research centers in minority institutions, our researchers and principal investigators have garnered millions of dollars in grants from federal agencies to discover new ways to treat the various forms of cancer that affect people of color the most. The college is ranked high for its impact in research designed to promote treatment and eradication of diseases like cancer. A funding report by the American Association of College of Pharmacies names the FAMU College of Pharmacy and Pharmaceutical Sciences the largest recipient of National Institute of Health research grants among all Florida pharmacy programs, as well as the University of Georgia, Auburn University, and Samford University. With the American Cancer Society projecting that the number of cancer cases in Africa will double by 2030 to 1.28 million, we look forward to the impact the African Cancer Foundation will have on helping to decrease these numbers, and also look forward to working with each of you to eradicate cancer for good from the continent to continent. Again, thank you for joining us today and for your contributions to making our world a healthier place. Thank you very much.
I want to extend a hearty welcome to Prof. and Mrs. Nyong'o for making it to Tallahassee to be with us. We are a college of pharmacy that's focused on research in many different ways. We have looked at research in health disparity areas, several health disparity areas, including cardiovascular diseases, but cancer in particular, because cancer affects our people more than it does any other group of people. And we have done some things that extend around the world, in fact. We have been to Ghana. We have sent people to Kenya. We are working with Tanzania to get natural products in Africa that could be used to treat cancers and other diseases. It is expected that we'll be signing some agreements with a university in Tanzania pretty soon, and would have people come to Tallahassee to do some research, and we plan to go there as well to do research with the people who are there. So this is special to us, and I want to thank you especially for agreeing to partner with us in this direction. I hope we can come to some conclusion as we prepare for the next phase of this development. So please join me in welcoming Professor Nyong'o and Mrs. Nyong'o to the College of
Good morning. Good morning. Good to see you all this morning in Sunshine State. Yeah. Great. Okay, so my name is Dorothy, and we're going to do this presentation in two parts. I will tell you about how and why we started the Africa Cancer Foundation and the background and a little bit about the work we've been doing. And then my husband will come in and paint the picture of Africa, and together we shall try and find solutions for the way forward. So the year was 2010 when the word cancer hit us. And I remember we were in Malaysia for my daughter's graduation from Nottingham University. And before that trip, my husband had stayed behind to go through some tests, a biopsy. And he also left us after the graduation to go back and got his results when he went back to Kenya. I stayed on with my daughters to have a little vacation. But the message that he sent the following day after his arrival back in Nairobi, I will never forget. He sent a very brief text message that said, a few cancer cells have been found. And my head went into a spin. You know, we did the vacation and came home. The whole time I was just thinking and wondering, and every time I could get a chance, I would call him and speak about it, but we didn't want to alarm the children, so I didn't share any of that with them. So a few months later, we started the process of trying to find out what to do about his diagnosis. And in the search, and it was quite a search, because we were asking questions, we were trying to understand terminology, and the whole field was very new to us. In the process, we ended up at a hospital that my nephew recommended. My nephew is a pediatric ophthalmologist in San Francisco, and he connected us with one of his old professors, Dr. Mark Roach, who then took us through the radiation therapy treatment for his prostate cancer. And that went well, and we were done by February of 2011, and we went back home. But what hit us while we were in San Francisco was that we realized, it dawned upon us that there was a huge knowledge gap on cancer in Kenya, at least, if not in the rest of Africa, because we consider ourselves fairly educated, fairly enlightened, and fairly global. And at that point, my husband was the Minister for Medical Services. Why was this cancer word and world so foreign to us, so distant, so just mystical? Why? Why was it not something that we were more familiar with? As I mentioned, the terminologies and just the whole experience. We read a lot while we were at UCSF. We went into the internet, and we had a library at the Helen Diller Resource Center, and we read a lot, and we had support group meetings, and we attended lectures on nutrition and the effects of chemotherapy and radiation therapy and the importance of exercise. And as we listened to all this, it just dawned on us that we need to do something about this for our people. Because we told ourselves, if at our level we were so dumbstruck by this disease, what about the ordinary Kenyan or the ordinary African who has no idea? This was something that we decided that we have to tackle. And we also told ourselves that, okay, we have hospitals that are doing something. We have doctors that have been trained. But we realized that the services were not enough. But the big thing that we realized was that if the people themselves didn't know or understand cancer, even if you had state-of-the-art facilities with the top doctors, it wasn't going to help. So we decided to go and start from the grassroots. And our focus then, when we launched the Africa Cancer Foundation in July of the same year, 2011, was to do grassroots awareness and provide early screening so that we were going to create a demand from the bottom up, so that people would begin to look for services and eventually force the government to pay attention to the disease. He was, as I mentioned, a medical minister, but the bureaucracy in government, you all know about that. So the impact at government level was too slow for our liking. We needed a movement. We needed to create a movement from the grassroots. And so that's what we focused on. And so over the past 5 years, what we've been doing in Kenya is creating awareness. We developed some fact sheets which we distribute freely. We have cancer camps around the country, and we also send them out by email so that people can share them electronically as well. We also developed some books, cancer books, that we actually, what we did is we made them appropriate for local use. They were developed by the American National Cancer Institute, but what we did was to domesticate them, having images of black people and referring to institutions that existed in Kenya and so on and so forth, so that people could actually relate to them. And the 4 main books that we developed were one called Eating Hints, which gave tips on what to eat before, during, and after cancer treatment. Another one was called Taking Time, which introduces people to the whole concept of cancer. When you get a diagnosis of cancer, what do you do? And what are your likely feelings, depression, anger, denial, all that. It deals with that. And also talks about what relatives and friends can do to support someone who's going through a cancer journey. And then we looked into chemotherapy, and we also looked at radiation therapy, because those are the main courses of treatment. So these books are available, and we give them free of charge to people with cancer and to their families, and they have been very useful. Then a year later, we felt the need to start providing screening, because we realized that people were walking with cancer, and in most cases, by the time they go to hospital with symptoms, it was usually too late. Cancers were being diagnosed at stage 3 and 4, and of course the prognosis was not interesting. And so we said, okay, let's work together with government and private hospitals and provide cancer screening so that people get into the habit of going for screening or checking with their doctors at least once a year. There are people who've never seen a doctor because they've been okay, and so they don't feel the need to go for a regular checkup. And we wanted to create that culture that even when you're well, you need to go and be checked. So over the last 5 years, we have screened in 11 of the 47 counties in Kenya. Our focus has been on the 3 main leading cancers, and that is breast and cervix for women and prostate for men. These are also the easiest to screen. And so we've reached out for partners, and we go into a county, we set up a camp with tents, and we bring in the personnel from the hospitals, because we're not clinicians, we are not medical people ourselves. So what we do is the partnership. So we bring them in, they bring the couches and the equipment, and we raise funds for the camp. And each camp costs us about between $10,000 to $20,000. And we run the camp for about 2 days. We normally see an average of 500 to 800 people every day. So in one camp, we may see about 1,500 to 2,000 people. So we've seen about 15,000 people in the 11 counties where we have screened. We've been getting some painful stories from the ground. Some people come in and they're coming in with all kinds of cancers. So it's not just that they walk in for a screening. Some of them have visible tumors and lesions. And so what we do is we channel them back to the health facilities so that they can be followed up. It's been quite evident that there's a major barrier to accessing healthcare among our people, particularly among the poor. And that is the cost of healthcare, and as I mentioned before, even the physical access. And we felt that we need to remove this barrier. And at some point, I think my husband will talk about the need and his efforts to bring about universal health coverage in Kenya. I'll just give a quotation from one satisfied lady who sent us an email after one of our screenings. And she said, "Today I bring a message of thanksgiving and gratitude for the good work you are doing. Following your visit in Nyeri, we found out that my mom could be at risk of developing cervical cancer. We acted so fast and had her uterus removed on Monday. And thank God she's responding well to medication. You really saved us the tough moments in the future. Thank you and keep it up." And so when we get messages like this, it really spurs us on. We say that even if we touch one life, that's enough for us. We have worked really hard. We're very small, by the way. The foundation is very small, but we have a pool of volunteers, and many of them are university students. We have about 800 volunteers who, when we go out to run the camp, they show up and they do the work that's needed. And it's usually a lot of work, ushering people, taking them to the various tents for the screenings, even providing counseling services and so on. So that is the pool that we rely on, and that has worked really, really well. 2 years ago, we decided to register an Africa Cancer Foundation USA, and that was successfully incorporated in December 2014, and it's a 501c3 organization in California. And our international partnership has also led us to Oracle. And with Oracle, we developed a mobile app for collecting data when we go for screening. So we don't have to kill too many trees by filling in the registration forms and so on. So the mobile app allows us to get all the information, and then we send it up in the clouds, and we can look at the data and figure out how many cases we had of this, and all the data is available to us that way. We also partnered with an Israeli organization called Mobile ODT, and they have developed a colposcope, a handheld colposcope, that can be used in the field very easily to screen the cervix. And our screening for the cervix is by use of iodine or vinegar. And so when we have the mobile ODT colposcope, it enables the medical personnel to look and see very clearly in the cervix and to take a photograph that they can then show the patient or the client to see what the cervix looks like. I bet all of you women in this room have never seen what your cervix looks like. So it's very powerful. It's very powerful that you can be seeing what your cervix looks like, and if there's lesions, the medical personnel can explain what's going on, show you a normal one, and what's going on with yours. And in the partnership, we are able to, we also partner with organizations like Maristopes, who provide on-the-spot cryotherapy for lesions that need that. So with that service, it means that the lady who gets that cryotherapy treatment is free from worry about cervical cancer for at least 10 years. It's a 10-year guarantee. And so that partnership has been really great for us. The company gave us 15 of these colposcopes, and what we do is we train our volunteers, the medical students, and we train them to use this, and they're able to do the work when we go out to the camps. So for them also, it's such a great learning experience because they don't have this in their schools. So when they go with us, they actually learn a lot. They see a lot, and they learn a lot. Now, the other thing that this mobile ODT colposcope can do is that the clinical personnel can share this image, if in doubt, with a higher level medical practitioner anywhere in the world, yeah? So long as we have internet. Share that and get feedback. So we actually have not gotten to that point where we needed to do that, because we've had local medical personnel who can input in that decision making. But that option is available. And related to that, we partnered with an organization called BRIC that provides us with internet when we go out in the field. Because when you're out in the field, really, there is no, sometimes there's no electricity and there's no internet. So BRIC comes along with us and they provide us the internet. So as we take the data on the phone, we're able to send it up in the cloud, and if we needed to share this image with a practitioner somewhere, that would be possible. Our partnership also led us to Slovak Aid that funded tents, because when we were going out into the field, we always needed to hire ground and hire tents that we can then subdivide for privacy, so that everybody gets like a private consultation room. And so Slovak Aid helped us, and we got funding, and we have our own 4 tents that divide into 4 rooms each. So we, at any camp, we have access to 16 rooms for consultation. In the process of our work, we spearheaded in Kenya the development of cancer guidelines. And we worked closely with the Ministry of Health. And 2 years ago, they released the cancer guidelines. Actually, 3 years ago, the National Cancer Guidelines for Kenya. So that has been a big achievement, because there were no guidelines. So the doctors were, at the various levels, health facilities, didn't even know what to do when they came across a case of cancer. We also work closely with other organizations in Kenya, and we set up 2 years ago a Kenyan network of cancer organizations, KENCO, and all the cancer organizations are under this umbrella. And so we partner for screening, for awareness, for support group meetings, and so on. And so that dream we had of having people work together to deliver services, that is beginning to take shape in Kenya. In 2013, ACF received a Rockefeller Foundation grant, and in collaboration with the United States International University, Africa, which is based in Nairobi, we carried out a study on the prevalence and capacity of cancer diagnostics and treatment in Kenya. And the purpose of that study was twofold, namely to document the prevalence and types of cancer in Kenya, and to determine the diagnostic and treatment capacity of the various health facilities to handle cancer cases. So the study was focused on 10 out of the 47 counties of Kenya, And I will jump directly to the conclusions and share that with you. So it found that on the demand side, the demand for cancer services is high and will continue to grow. This is in contrast to the limited capacity with respect to diagnosis and treatment, which has had implications on issues of access, proximity, and availability. It's also clear that among the cancer patients, awareness is very critical, especially as evidenced in some lifestyle practices, which, according to other studies, could make a huge difference of up to 40% in prevention of cancer. From the demand side perspective, the study recommended that cancer services be widely spread into the rural areas, especially at community level and clinic level, which tend to be the first points of contact, and also where most of awareness is lacking. It also emphasized that more attention should be paid to children with cancer. And finally, it is recommended that more preventive attention be paid to females, especially at a much younger age, including programs in primary and secondary schools. From a supply side perspective, and with respect to accessibility, it was recommended that subsidy programs, including donor appeals, be made similar to the HIV/AIDS initiatives to avail screening and treatment services to those without means. These could be channeled through cancer foundations, which would target risk sites and vulnerable populations for assistance. The proximity problem could be addressed, as stated, by directing resources to rural areas at community clinic levels. Finally, it was recommended that the HIV/AIDS model be encouraged among public facilities so as to benefit from economies of scale, especially from smaller facilities. One of the things that was evident during the study was that most of the cancer facilities are in the major city, not even cities. So they are in Nairobi, both public and private. There's a little bit in another city called Eldoret, and a little bit in another one called Kisumu, and another one called Mombasa. And the rest of the country has almost nothing. That was way back in 2013. Since then, the layout of the country has changed because we adopted a new constitution in 2010, which created the 47 counties that I mentioned earlier. So because we have the 47 counties, a lot of services have now been devolved. And health is one of those services that has been devolved, which means that there's a new opportunity for the counties to beef up on their medical services, especially with regard to cancer. And I will allow my husband to speak more about that, especially because he is most likely the incoming governor for Kisumu County. So he will be able to think about what he will do for cancer work when he becomes governor of Kisumu County in on August 8th, 2017. But just before I hand over to him, I want to leave you with a quote from Olusegun Obasanjo, former president of Nigeria. He says, we cannot afford to say we must tackle other diseases first: HIV, AIDS, malaria, tuberculosis, and then we will deal with chronic diseases. If we wait even 10 years, we will find that the problem is even larger and more expensive to address. Thank you.
Thank you very much. First, I'd like to thank Dorothy for a very competent talk, really. She always does that, and then renders me rather incompetent following what she has said. But let me also thank Yusuf for inviting us here, and Keris Taviere, the two of whom have extremely been persuasive in bringing us here, and we were looking forward to having this discourse with you this morning. Mine will be very brief. First, to just fill in a few gaps. When I became Minister for Medical Services in 2008, I had previously been Minister for Planning and National Development in the reform government of the National Rainbow Coalition. In 2003, we were in government for about 3 years before we disagreed with the president and went out as a party. But during those 3 years, one of the things that happened is that I was very much engaged with the then Minister for Health, who was part of our coalition side, in trying to get universal health coverage introduced in Kenya. And we didn't succeed because of resistance from private pharmaceutical firms, private health providers, and conservative businessmen, and so on. So then in the next government, which was also a coalition government, I asked my party leader to move me from planning to health, because I was very passionate about universal health care. Little did I know that I was running from the frying pan into the fire, because being in health became even more difficult to try and get universal health care done in Kenya. But at least we managed to move the debate forward and undertake substantial reforms in the National Health Insurance Fund. And Yusuf has studied our insurance fund, and that's a story he will tell you one day. One thing that occurred to me when I was Minister for Medical Services, because health was divided into medical services and public health, which was another problem we had. One thing that occurred to me when I first entered the ministry was to ask my Director of Medical Services, what is the geography of diseases in our country? Where do we have problems? So we went round and round, and it came very clearly that we had a big problem with cancer. Then I said, okay, fine, we have a problem with cancer. Do we have any book or any record on these diseases and how they are diagnosed and treated and so on? And he brought me a volume this thick. In that, what was called guidelines to treatment and diagnosis of diseases in Kenya, there was not a single line on cancer. So I said, well, if cancer is such a big thing in this country, how come we have nothing to do with this diagnosis, treatment, and care in the country? So I said, well, Mr. Minister, to tell you the truth, we have always thought that cancer is such a personal disease that we leave it to individuals to deal with it, which I thought was an extremely irresponsible response from a medical doctor. But little did I know that 2 or 3 years from then, I'll be victim. What is interesting, which Dorothy didn't tell you, is that our family, we were very particular about having medical checkups every year. And I had 2 doctors, my physician and my doctor who did my medical checkups every year at a private hospital called Karen Hospital. So I was going to my physician for regular checkup, and then when I went, he said, well, you know, urine retention is not very good. So I said, what is that? He said, well, you are not retaining urine very well. I said, well, what does that mean? Okay, so we went for tests and so on. And after some time, without telling me much, he said, well, I'm referring you to a urologist. So refer me to a urologist. Then your urologist told me, I'm referring you to an oncologist. Now, these words, I didn't care, even as a minister for medical service, to find out what they meant. So from one gist to another gist, I got attended to. What is interesting is when I went to the oncologist, he told me that, look, I noticed something not very usual with your urine retention, and I think we need to give you some antibiotics and see how it goes. I don't think it's cancer, but even if it is, it doesn't kill. And I believed him, because we have this tendency of believing doctors and putting all our faith in doctors. I was a minister and I was putting my faith in a doctor, completely. But then one day, I got an email from my doctor, who does physical exam for me every year, and said, look, can you come in September for your annual physical exams? I said, fine, September is a little bit far. It was now July. So one day I was driving to the African Academy of Sciences in Karen, and I said, well, why don't I just drive to Karen Hospital and get my medical checkup early than usual? Which I did on a Thursday. Dr. Dan Waconia, my doctor who was doing physical exams, told me, okay, fine. We are going to do all the parameters. We take a whole afternoon, did everything, endoscopy, you name it. Then I told Dr. Waconia, look, I'm going to my constituency tomorrow, which is Friday. If you notice anything unusual, please call me, because I'll be in my constituency until Monday. So on Saturday, he called me in the morning and said, Prof, I see something rather unusual about your PSA. I said, what is that? He said, PSA. I said, I don't know what that is. Well, he said, look, what you do on Monday, go to your urologist or oncologist. I will have sent the reports to him. And what you do, tell him that I am demanding that you go for a biopsy. All these things were new terms to me. So on Monday, I go to my oncologist, stroke urologist, and said, okay, fine, we don't do biopsy here. I'll send you to MP Shah Hospital, where Dr. Handa will do a biopsy. So I went to Dr. Handa, and my family already left for Malaysia. I was following them. So Dr. Handa did an extremely painful thing without anesthesia. You know what I mean? Baby men do. But if somebody is doing a biopsy without anesthesia to a man, it's extremely painful. And he had to take 16 samples with this gun, poop. And at the end of it, I sat on a bench for about 20 minutes, not knowing what had happened or where I was going after that. But then I stood up stoically and left and told him I'm going to Malaysia and I may be back after a week. He said, that's okay, because we're taking some samples to South Africa, and maybe they'll be back the week. After you come and see me, we'll tell you what the results are. So I went to Malaysia, as my wife was saying, and forgot what had happened, because I was enjoying myself. So when I got back, the story that she told you, then it dawned upon me that something had been serious, and we need to do something about it. And of course we did, and as he said, that led me to the University of California, San Francisco, under the care of Professor Mark Roche, a leading prostate oncologist globally, who has written huge books on this subject. So I was very lucky and happy to be under the care of Professor Roche and Professor Peter Carroll, who is a surgeon. Roche is a radiologist. Both of them explained to me exactly what was happening. Both of them decided that in my case I needed to have radiation, and they told me at the end of it, things will be okay. And at the end of it, we rang the bell at the Helen Diller Comprehensive Cancer Care Center, and when you ring the bell, it means you have successful treatment, and we left. But, as Dorothy said, we said, no. If we can be this ignorant what about the ordinary Kenyan? And we decided to found the Africa Cancer Foundation so that people should not fall in the same trap that I did fall in. And when we launched the Africa Cancer Foundation on the 11th of July 2011, our motto was the following: we can because we care. We can because we care. We can make people aware of cancer because we care. We can demystify cancer, that it's not a killer disease, but discovered earlier it can be treated. And that one of the most important things that we learned was that prevention is important and awareness is vital. With those, a lot of lives can be saved. But when we went back to Kenya, we said, yes, prevention, awareness, there's also diagnosis, treatment, care after treatment, and of course, family care and community care. All these are important in dealing with cancer. So we decided really to start the Africa Cancer Foundation in an environment where there was very little knowledge, even among doctors. Let me say that. Because one of the leading oncologists, Professor Abinya, who is a fantastic man, we talked to him. I said, look, I am a cancer specialist, but let me tell you, I'm very lonely because there are very few of us, and there are some people who masquerade as cancer specialists. They're doing us a lot of harm. So he hoped that since I was Minister for Medical Services, we would work together and improve the atmosphere. I didn't tell you that when I was in California, I was still contributing regularly to the column that I write in the weekly newspapers. And I did write 3 articles on what we are going through. Those 3 articles did a lot of good because they also made the private hospitals aware that they should start cancer treatment and care. Nairobi Hospital started an oncology and cancer center. Aga Khan Hospital started a cancer and heart center. So by the time we went back to Nairobi, although there had only been cancer treatment at Kenyatta National Hospital, another cancer center, MP Shah Hospital, 2 more had come up. But the trouble is, and let me say this, is that as more people realized that it was possible to have cancer centers, we started getting a mushrooming of clinics around Nairobi, which claimed that they could do cancer diagnosis and treatment. And it was now upon the government, and I was Minister for Medical Services, to establish regulations to ensure that we don't have too many quacks, misleading people, and giving wrong treatment. The battle continues because it has not ended. That as we demand much more cancer care and cancer treatment and diagnosis, there are those sharks and merchants of death which jumped into the fray and capitalized on people's ignorance to say they are providing cancer treatment or cancer care. That's part of the awareness that we are also involved in, with doctors, clinicians, and so on, with people who are already doing that. For example, the Faraja Center at MP Shah, 2 doctors running the Faraja Center, fantastic center for cancer awareness and counseling, one of the best in Kenya, by the way. If you come, we work with them. And I think they're doing a marvelous job. Now, let me now maybe give you some depressing stories. I hope you don't mind. About the state of cancer in Africa. The figures are rather depressing because it means that there's a lot of work to be done. Cancer, as Dorothy said, has emerged as a major public health problem in sub-Saharan Africa, and Yusuf knows that. In females, but let me go back a little. That is because of other diseases too. HIV/AIDS makes the situation rather complicated. Human papillomavirus, hepatitis, and so on. These are the diseases that I think you people have to deal with, also having an impact on cancer prevalence. In certain sub-Saharan African countries, you can find that about 1/3 of all cancer cases in the region is estimated to be infection-related, related to infections from other diseases. So it means dealing with those other diseases will have an impact on cancer prevalence. Now, in females, as Dorothy said, the numbers of cases and rates of breast and cervical cancer are almost equal and comprise 50% of the overall cancer burden in sub-Saharan Africa. In males, cancer of the prostate dominates in terms of the number of cases. 27, almost 30% of the total estimated cases in sub-Saharan Africa. So prostate cancer dominates, followed by other forms of cancer. Now, when we did our study in Kenya that Dorothy was talking about, of these 11 counties, we did find that in certain regions, certain forms of cancer are prevalent. We don't know why. Like in the Rift Valley, in Southern Rift, there's a very high prevalence of throat cancer. In Masailand, like Transmara region and so on, there are rising cases of prostate cancer, much more rapid increase in prostate cancer than other areas. In our own area, Nyanza, Kisumu, and so on, breast cancer, cervical cancer are much higher than in other areas. The only other region that competes with that is Nyeri, for some reasons we don't understand. So maybe you as researchers, you see when you bring your students, you may help us in carrying out research in these areas, finding out whether some environmental or economic reasons or cultural reasons why certain forms of cancer are more prevalent, even in Kenya, regarding which country you're dealing with, which region you're dealing with. That may or may not help advance diagnosis and treatment, but something as scientists worth pursuing so that our knowledge can be improved. How to prevent cancer and how to diagnose the causes. Now, what is encouraging now, apart from giving you the sad news, what is encouraging that over the last 6 or 7 years, there are many organizations that have emerged at the continental level that are dealing with cancer. And they're doing a good job. For example, the Independent Clinical and Ecology Network, ICON. Since it was founded 8 years ago, ICON has made its presence felt by reducing the cost of cancer treatment, increasing the utilization of appropriate generic cancer drugs has been one of ICON's missions, and the benefits are there for non-medical aid members as well, resulting in better and more cost-effective treatment for all cancer patients in sub-Saharan Africa, particularly South Africa. Let me tell you something about this. Pharmaceutical industry, and this is a school of pharmacy. My experience as when I was Minister of Medical Services and as a Kenyan is that pharmaceutical industry is a very wicked industry because it has very little feeling for poor human beings. The cost of drugs, of diseases like cancer, is just too high. And then our hospitals don't make it any better by loading more profit on these very expensive drugs. Our governments don't make it any better by not having universal health care to make it possible for poor folks to access these drugs. Secondly, cancer care, good cancer care is only available in private hospitals, private health facilities in Kenya, which creates a barrier between the common people and access to health care. Something needs to be done. And I think the initiative by bodies like ICON should be supported and encouraged. A more intervention at governmental level be done to have cheaper drugs. Because I believe, like Dorothy was saying, when we started with HIV/AIDS, originally the drugs were extremely expensive. But all forms of intervention has made it possible for people to access drugs. That now makes it possible that if you are diagnosed with HIV/AIDS at the age of 15, you are sure you'll live into your 70s. I think maybe the same philosophy or approach should be done with regard to cancer drugs. Now, the other organization which I want to mention is the African Organization for Research and Training in Cancer, AORTIC. It seeks to become the continent's preeminent non-profit organization working for cancer control. AORTIC will achieve this through the facilitation of research and training, as well as the provision of relevant and accurate information on the prevention, early diagnosis, treatment, and palliation of cancer. It is dedicated to providing all Africans with these benefits, as well as to increasing public awareness of cancer and reducing the stigma associated with it. Now, this is the kind of organization that we as Africa Cancer Foundation would like to associate with, because they're doing the same thing as we are doing on a much larger scale and perhaps better endowed to do so. But we are kind of low-level operators. They are a little bit higher level operators, but we need to make our people aware that such organizations exist, and we need to bring them to the grassroots to help us do what we are doing. And finally, let me say something about the cost of and access to pharmaceuticals. With regard to cost of drugs, availability, controversies, and so on, it is said that by 2030, according to the International Agency for Research on Cancer of the World Health Organization, it is estimated that new cancer cases in Africa will increase to about 1.4 million people each year, with 1 million people dying due to the disease. African countries face many challenges and are under-resourced and ill-equipped to deal with the growing cancer burden and its devastating impact. Cancer therapy is one of the most expensive aspects of healthcare, as it embraces screening, diagnosis, treatment, surveillance, and palliative measures. Unlike most countries that share the cost between government and insurance partners, in Africa, most patients and their families have to bear the cost of treatment from already meager resources. This can be attributed to the low percentage of resources allocated, health budgets, and the fact that cancer control is the least amongst the priority list, competing with communicable diseases and some other non-communicable diseases. Cancer doesn't seem to receive a lot of priority in other African countries. I think Kenya is now increasing. If you compare Kenya and Uganda, Sudan, there's much more awareness at governmental level that cancer should be prioritized. And that should happen in almost every country. But in the final analysis, the cost of drugs and access to drugs will still be extremely useful. Now, let me give you just one final example. Both as Minister for Planning and Medical Services, I visited Cuba. And I was very impressed by the Cuban health system, particularly the Cuban Institute for Biotechnology Research, and another organization called LabioPharm, which is a pharmaceutical firm deriving its work from the Institute of Biotechnology. These two are interdependent. And they have made it possible for the Cuban government to develop very cheap vaccines and to start a research on cancer drugs, which I think, from what I read and from what I told when I was in Cuba, was rather promising. I learned later in 2011 that the Cuban Center for Molecular Immunology had discovered a vaccine called Sinovac against lung cancer, and through their national immunization program would soon make lung cancer history in that little island. I did not believe it myself. having myself been smitten by the envenomed tongue of cancer, I was deeply frustrated that I never made headway in establishing a research center for oncology and genetic engineering in Kenya when I was Minister for Medical Services. Although such a center of oncology and genetic engineering thrives in Cuba, we are a much bigger population than Cuba, with an education system capable of attracting all kinds of brains from all over the world, and yet we're not using that comparative advantage. In other words, true or false, at least I did learn that some effort was being made by Cuba in developing a vaccine against lung cancer. And it had a name, Simavax. Cuba is a much smaller island, little population, not as endowed economically as we are in Kenya. And yet, we who have tremendous access to the external world, and people like you can invite researchers to come and help us, we have not made any such effort to use and exploit the benefits of science and technology so we can have vaccines or drugs that can deal with cancer. Somebody has to do it. And we can't wait for somebody else to do it. We have to do it. And as Dorothy said, from Obasanjo saying, if we wait 10 years to do something, it may be too late. Together, I think we can do something. So our plea as we come here is that we can collaborate in these areas. I think what lacks in Kenya is that maybe our universities have not been too attentive to comparative research and collaboration with much more advanced institutions like yourselves. And I think knowledge is a social good to be shared among people and among civilizations and not to be monopolized by anybody. And whoever invented something called a patent knew that knowledge had to be rewarded, but in the final analysis, it must be used for performing some common good. So I hope that what we started as awareness will go beyond awareness to make us more aware that in the final analysis, when an individual is smitten by the envenomed tongue of cancer, that they will find solace knowing that, like TB, there is now a cure, and cancer will likewise get a cure within our lifetime. Thank you.
Thank you so much for your accepting to come to the Hills and willing to work with Florida A&M University to contribute the little that we can to tackle this major world issue. So our interim dean is not here, and I would like Dr. Brown to come and bring greetings from the Director for Institute of Public Health, Dr. Perry Brown.
Good afternoon. I was asked by our Director of the Institute of Public Health to represent her. She is not able to be here today to bring you greetings from IPH. The Institute here was founded in 1995 in part as a response to what was known as the growing inequities in health and disease outcomes. Much of what you've experienced with your foundation in Kenya, we've also experienced here. And so there are a number of parallels that I think that come to mind. And as you were making your presentation, I was thinking, parallels, is what we see. And our societies do not exist in a vacuum. We share a lot of the same issues. We share a lot of the same problems with access to care, affordability of care, access to information, and developing even more preventive services and activities, because prevention is a heck of a lot cheaper than cure. And so I was heartened, as you mentioned, that you had received a number of materials from our National Cancer Institute. Those materials have been used worldwide. I hope that you may have adopted some of those for Kenya, because what may be appropriate in Tallahassee may not be appropriate in Nairobi. And so we're heartened, and we're also very complimented by the fact that you've come to NCI. Within the Institute of Public Health, I know that you may have walked around through our halls. Today's the first day of class, but we do have expertise in maternal and child health. We have expertise in health education and behavioral sciences. Indeed, you met Dr. Lee last evening. We have expertise in environmental and occupational health, as well as in health policy. And so some of the ideas that you put forth about national health insurance or affordable or universal health care are the same kinds of issues that resonate here, as you probably know. We have expertise in epidemiology, certainly Dr. Dokurugu, who would claim that he is an epidemiologist, and I would back that up. He was trained by an epidemiologist. As you mentioned, Oracle and data in the cloud, I must admit to being part alien because my antennas came up. I love data. I love data. I think the Institute, it would be fair to say that the Institute of Public Health here welcomes the opportunity to partner with you going forward, to help identify some common goals and approaches to the issues that you face in Kenya and perhaps even across sub-Saharan Africa. I think that the comment from the former president of Nigeria is absolutely on target. If we wait to deal with the exigencies of our present, it will make the problems of our future so much greater. And so the priorities sometimes may be short-sighted in the long run. And so we can't wait to get malaria under control before we tackle cancer. We can't wait to get HIV/AIDS under control before we tackle some of the other chronic conditions, because they will just continue to increase. So once again, welcome on behalf of Dr. Cynthia Harris and the Institute of Public Health, and we look forward to some continued dialogue and identification of some aspects of our continued collaborations. Thank you.